Alabama EMS Challenge. We're in Springville. Thanks, guys, for having us today. Great facilities, always a great turnout. EMS Challenge is a program we started, for those that aren't aware, back in 2014 to bring physician-led Con Ed to the region. We started at Highlands Hospital doing 1 day a week. We are now doing, we good, sir?
Yeah.
Okay. Okay. I just hear profanity, so I'm just making sure.
We're already getting questions about the protocols. You haven't even started talking.
Version is to go more docs into the field, like it seemed like there were more when I was doing EMS years ago. So that's the goal of this. We'd like to thank, all the partners. Fire College sponsors us to get us out 1 day a month. Couldn't do it without those guys. We started just at Center Point, and Jeff State was sponsoring us, but I really appreciate all the support. Springville's been a great supporter of us as well. So thanks for doing that. For your certificate today, for those in the class, we already kind of talked about we're going to do that. We'll put the QR code up in a little while. Online, there'll be a link you can use. You can always email alabamaemschallenge@gmail.com to get your certificate. Try to do this today by this afternoon so we can get that kind of pushed out. There's been a little bit of delay in getting some of the certificates out due to the fact that we're changing some of the software we're using. So if you don't get it in a day or two, no worries. If you don't get your certificate within 4 or 5 days, give us an email and we'll make sure you get that stuff. Remember, we do have our YouTube channel if you need Con Ed for the upcoming research cycle. Things we got coming up in the future, we're going to start, hopefully COVID is going to allow us to gather more at BRIMS, and we can do some of the regional out-of-hospital cardiac arrest training that we talked about, some of the skills for both the EMT, the advanced, and the paramedic. We'll be at Centerpoint on the second Wednesday of February. We're working on the fourth Wednesday of February. There's a national conference, CCTMC. It's geared more toward critical care paramedicine, the flight guys and the ground critical care crews. It's at Orange Beach in April. National conference in our back door. Guys, you need to go to that if you can, our backyard. GEMSCon, so the GEMS conference has joined with FDIC and it'll be in April up in Indianapolis. So those are just things we're being involved with. And then hopefully we have some podcasts coming out to the BRIMS region in the next few months. We're just trying to get the staffing where we need to get that. The SMEC in June has been canceled. And just kind of regional updates. We put a death in the field memo out several months ago, and there are questions been sent to me about that. The short version of that was nothing has changed the way we talk about ceasing resuscitation in the field. It was just a reminder that if you're going to call med control to say, I don't want to work this patient, you need to actually look at the patient and touch them, not just look through a broken window to make sure they're dead. Now, if the head is missing from the body, that's reasonable. But if they're intact, you got to actually touch the patient to make sure they're dead before you don't try to resuscitate them. And the other thing is, I would kind of like people to kind of get away from using the phrase time of death. Just for medical legal reasons. If you're documenting, maybe put, time resuscitation was ceased or not started. Law enforcement, some of the coroners are still using the time that we get from med control for time of death, and that's fine. But from an EMS, ADPH standpoint, we're not really pronouncing someone dead. That's a legal term. We're just saying, yeah, you are dead. We're not going to work you. So that makes sense. Thanks for almost smiling. Great. It's a tough crowd today. Good. Ketamine, remember ketamine is ideal body weight dose. If you have issues with that, reach out to me. I can get some cheat sheets to you. All right, but very important. Also remember that post-ketamine patients are critical patients. You expose them, they get on the monitor. You look for life threats. If they become hypoxic, you don't just give them open and ventilate. Make you hypoxic. Ketamine makes you quit breathing, which makes you have problems. So if you just throw O2 on those folks, you can have a bad outcome. And then protocols, and I think that's what a lot of folks want to talk about. Has anybody seen the new protocols on the webpage? Yes, no, maybe. All right, I'm going to try to switch over. So these were posted on the webpage. I know there may be some edits coming out. Tentatively, the date to start was April 1st. We'll see if that's what we're going to go with. The big thing on the protocols that I would say is a couple of things. One, don't look at it now because you're going to get confused. I'm going too fast. As you can see, we're switching from the color coding on the side to more of a flow chart. You'll also see there's some abbreviations on the side as well that talk about this will be like the advanced can do this, the intermediate, the paramedic, or critical care. The protocols are combined, so the general patient care protocols and critical care are all in one book. So you'll see there's a lot of more medications. That doesn't mean all these meds are going to be going out for general patient care use, but they're all in the book, so it's just one location for you. So on
that note, we've already had a question, and the new protocol has a C listed in the general patient care protocol. Does this mean now that a critical care medic can operate as a critical care medic even if the service they're working for is just ALS?
No, sir. No, sir. The state is not licensing critical care medics to work inside an agency that's not licensed to be critical care. Good question. Yeah. I think the big things that are going to affect general patient care protocols is the changes for the advanced EMT. So the advanced EMT, when these protocols go into place, will be able to use Epi 1 to 10,000 for cardiac arrest. They'll be able to use nasal Versed for seizures, for status. They'll be able to give TXA for hemorrhagic shock. And then there's some new drugs coming out, one of which is Toradol, which is a non-steroidal anti-inflammatory. So IV medication is like Motrin, but given IV. Don't give Motrin IV, just to clarify, right? Yeah, it's not funny. I say things because things happen, right? But those are drugs that the advanced can do. And the benefit to that was that way you can have, in the staffing shortages we have, you have the advanced that can actually give pain control for people. So that's going to be one of the bigger things we're going to have to do at the station levels. We're going to have to start training our advanced. These things were not in the initial program for you guys, so it's going to be all new. So for the medics that are working with advanced, we really need you guys to step up and help with the training on these things. We'll put out some training, kind of a overview of the way some of these new medications through BRIMS here pretty soon. We're working on dates right now. Questions about the advanced EMT stuff? And obviously, we're going to have a lot of protocol classes. I'll be touching on these at every EMS challenge between probably now and summer a little bit each time. Questions, comments? Any advanced in here? Anybody going to admit to it? Oh, good. Thank you. All right. Cool. Yeah. So it's a big change for the advanced. A lot of cool things. The Epi 1 to 10,000. You know, realistically, if you show up on scene and someone has no pulse, there's no risk to giving somebody Epi, right? So with VTAC, VFib, or asystole, Epi 1 to 10,000 is great. The Versed is one that you'll be able to give nasally, which is pretty good because that way, if someone is in status, just repetitive seizures, now you have a way to address that. So nasal Versed is pretty reasonable. If you give them too much nasal Versed, you need to manage the airway, but you should already be able to do that, right? With an OPA, a nasal trumpet, iGel, or BVM.
Will the state licensing process change like ALS 1, 2, 3, since advanced scope is changing?
Yes, sir. I do not know that one. That will be up to the state to determine. I don't know that one. Don't have a clue.
So I know a number of the services are operating on contract basis.
Yes, sir.
Like the private services. And
right.
That's usually part of that contract description.
Yeah. So that question probably needs to go to the state. I'm not sure. Sorry. Cool. The other big thing at the paramedic level is everything's going category A. I guess y'all heard that as well, right? Yeah. Nobody's smiling. Good. Yeah. So everything's going category A. There's really not a lot of new material out there for the paramedics. But the fact that everything's going category A kind of bumps up that responsibility. Okay, it does not mean you cannot call med control, but it means that if you know what you're doing, you understand the medications you're given, what's going on with your patient, and you don't want to call med control for things, you don't have to. The only thing that's staying Cat B this time will be intubating kids less than 3 years of age. Okay, so a lot of responsibility. If the way this is moving forward is the way I kind of think it should as well, is you as a medic or an advanced or an EMT should have a scope of practice. You know things that you can do. You have a list of medications, procedures you can do. You should understand those. You should be able to assess your patient and determine if any of these things are needed, and then you just practice within your scope of practice. So it's pretty powerful what you can be able to get out there and do at this point in the game. Questions, comments?
Will you address the tactical paramedic protocols? Because I know that was an issue, like everybody getting their TPC endorsements and tactical endorsements.
Right.
And so they could go category A when
right.
operating in that environment.
Right.
Now that everything's Cat A.
Right.
I know I've fielded some of those same questions from other organizations.
Yeah, so I think the issue there will be the surgical crikes. So I think to do the tactical paramedicine, the only thing additional will be the surgical airway. And to do that, you got to be certified by the state. You got to have an active medical director, and you got to be trained and checked off and have a quality improvement plan for surgical airways. Yeah, that's the big thing. The other big thing that's going to be coming to agencies is you're going to have a quality improvement plan. A lot of places already have that, but you're going to have something in writing that says we're going to look at these interventions that our guys are doing and these medications we're given, and we're going to have to go back and determine was this right for the patient, wrong for the patient, and how do we address that? So there's going to be a lot of responsibility put back on the agency to make sure things are done correctly. Cool. All right. Tough crowd. All right, Chief. Let me just hit the PowerPoint to go back to that stuff.
Yep.
Okay. And then slideshow. Sweet. All right. The first case. The first case is always the good beer, right? Not the bad beer. That's kind of funny. Maybe not. I don't know. Been a long week. So 55-year-old male, nausea, vomiting, and chest pain. So what do we want to do for this guy? 12 lead. Yeah. So obviously I talk about 12 leads all the freaking time, right? So 12 leads important. What are you going to do before 12 lead for this guy? Oh, y'all thinking way too complicated. Yeah, just general assessment, right? ABCs, you walk it up. What does he look like? What's his work of breathing, his skin color, just general patient assessment, right? And then vital signs on this guy. So I've been working with an EMT class at the medical school, and we were talking about history gathering. And, when you think about the way we train our dogs, we train them to go into a room, take a history on somebody. They come out, they wash their hands, they go back in, do a physical exam, they come out, wash their hands, and they figure out a plan and start intervening with that patient. And that's not the way that we practice, right? So we're going to do our history, our assessment, and our interventions all at the same time on people, right? It's all hands-on process. We do need to get some history on people and past medical history, things like that, but it needs to be purposeful, right? So I call it STMs, the stuff that matters in these histories, right? So if somebody's on a statin drug or they take Motrin every day, those things really don't matter. There are more things that are more important, right? So if somebody's having concerns for ACS, acute coronary syndrome, there are things that make a difference, right? One would be their age, okay? So the 20-year-old with chest pain, does that make you think heart attack? No, not at all. The 60-year-old that weighs 412 pounds and smoking a Camel? Yes, right? So those things kind of risk stratify your patient to determine how fast am I going to do things. Every patient gets an assessment. Everybody with chest pain, nausea, vomiting is going to get an EKG. But the order I do these things speeds up based upon their history, all right? So this 50-year-old guy, things I might ask, any history of heart problems. If he says yes, I'm still doing everything else I normally do, but I'm going to move a little bit faster. Hey, go ahead and get the life pack, get the Zoll, just getting hooked up on the 12 lead. I'm gonna start my IV. And as I'm doing that, I'm asking more important questions as well. So history of diabetes. They say yes, you say shots or pills. Keep it simple. If they're on shots, you assume it's insulin. It's bad outcomes, right? So again, in my mind, I'm risk stratifying this guy, potentially more sick. Does that make sense? Ask about medications. What medications will be important to ask in heart issues as far as past medical history? Yeah, why would beta blocker be important to know? What does that tell you about a patient? Aside from Alabama. That's funny. Yeah, they're not going to be tachycardic, right? So if they were dehydrated, if they were stressed out, if they were hypotensive, they couldn't mount a tachycardic response. Heart rate will be slow, right? It also tells you they at least have hypertension. Beta blockers are also used for chronic heart disease, so that gives you an idea they probably do have underlying heart disease. What other medicines are important to ask? Sir? Oh, I said, what did you say? PTE2? What? Yeah. Oh, yeah. Are they going to know what phosphodiesterase inhibitors are? No. So what do you ask them?
Are you keeping any kind of sport pills?
Yeah, right. Yeah. So you want to ask them, are they on Viagra, Cialis? Yeah. And nobody's going to answer that honestly in a crowd of people, right? So you got to ask that discreetly. Lean down, whisper, ask them, hey, dude, are you taking anything to help you out? Certain things, all right? If so, no harm, no foul, but I need to know because it might give you some medicine that could hurt you later, all right? Other medicines, maybe, are you on blood thinners already? Things like that kind of risk stratify. Tell you that the patient is higher risk for bad outcomes, right? Cool. Vital signs on this guy's heart rate is 68, respiration 14, blood pressure 160/80, and he's set at 99%. So those seem pretty reasonable, right? The other mnemonic I like is don't forget the underlying physiology, pharmacology, and you've already touched base on one of them. So always ask about the Viagra on folks before you give nitro, because if you don't, they're going to bomb the pressure out. But just common sense things that keep you out of trouble. That's his EKG. I'll let y'all look at that for a second. Think about it. So the way I look at EKGs is I say, are they too fast, too slow, or okay-ish? All right. Too fast, like what American Heart says, they go down the pathway. If it's wide or narrow complex, wide complex, you think VTAC, narrow is SVT or an atrial tachycardia. Too slow, I think about three things that cause bradycardia: drugs, electrolytes, or ischemia. Drugs, beta blockers, too many of them, all right? Or maybe somebody that has owned a beta blocker and now dehydrated, has kidney problems. That medicines last a little bit longer and they get bradycardic. Electrolytes would be what? What electrolyte makes you get slow? Hyperkalemia. Yeah, perfect. Yeah, and then ischemia. So a heart attack, ischemia, instemia can cause too slow rhythms. All right, and I use 50 to 150 being my numbers there, and then okay-ish, everything in between. And those are the ones that can get you in trouble, right? So calculating rate, everybody looks at the monitor. I say, look at the monitor, see what it says, throw your hand to the pulse. You can determine if it's regular or irregular. You can give you an idea if their skin is warm or dry. You check perfusion that way. All right, but then when you print these papers off, you always got to look and count your rate as well. The machine is not always right. So I use the box method, 300, 150, 175, don't care for a few beats, and then it's way too slow. And at these rates, I'm checking a pulse for too long, right? So I know they're bradycardic, so I'm gonna let go of that and start intervening for those people. Intervals, very important. What does a long PR interval tell you? Prolonged PR. First degree heart block. What does a first degree heart block do to people? Nothing, right? But what else can a long PR interval show you or tell you? Big red flag. So long PR interval makes me think hyperkalemia. That's one of the first signs, right? Textbooks talk about peak T waves. Don't really care about the T waves. When that PR interval gets long, it's concerning. So PR interval is important. QRS, if you don't know how to calculate a QRS complex, the width of that, you can't go down that algorithm wide or narrow. QT is pretty important as well. What is a long QT? What can it cause? Prolonged QT. What dysrhythmia? Torsades, right. So somebody who's passed out, you show up on scene, they passed out once or twice a day, they want a PRT, you do an EKG and the QT is almost as long as the R to R interval. That tells you that they've had a high risk for going into intermittent torsades and passing out, right? So that person, it's America. You can refuse to go to the hospital, especially where the hospitals are, right? It's not funny. But you can recognize that they're high risk to having a bad outcome and recommend they go to the hospital, right? Cool. What do you call it if you have torsades and it doesn't break and you pass out? You know what you call it? Yeah, cardiac arrest, right? Cool. Cool. All right, so this one, too fast, too slow, or okay. So the rate's okay, right? So the next thing I'm gonna do is I'm gonna look for injury patterns. I'm gonna look at leads 1, AVL, and 5 and 6. These are my lateral leads. I'm looking for ST elevation or depression. The next thing I'm gonna do is look at 2, 3, and AVF. Those are my inferior leads. The next thing I'm gonna do is look V1 through V4. V1 and 2 are your septal. These are your anterior leads here for elevation. And then you can also look in V1 through V4. Depression. So T-wave inversion, ST depression, anywhere through here is a posterior MI. That's enough data to put them in the STEMI system for me to call a cardiologist. Textbooks, some people talk about doing a posterior EKG where you move the leads to the back. That's fine if you got all the time in the world, but it's kind of more academic. In reality, if I see this is enough data that I'm calling the cardiologist to get them moving to the cath lab, right? The last place I look is lead AVR. Lead 1 and AVR should be opposite. All right, it tells you the lead's on correctly. And then if you're up in AVR and you got depression anywhere else, that's concerning for a left main disease. Okay, now it could be the old person who has bad heart disease that's now tachycardic or hypertensive or septic, or it can also be a new infarct that somebody needs a cath lab for. After I do that, I go back and look at my intervals. So I'll look at lead 2 first. It gives you a lot of information. Great way to look at the PR interval, the P wave. So PR interval, QRS width, and QT is what I want to look at. The next thing I do is I go over here to V1, and I'm going to look at V1 to determine if it's a left bundle or right bundle. That QRS complex is fine, so I don't even have to go to V1. All right. So now I've done looking at this one. Before I put it back down, I'm going to go back and look at leads 1, AVL, 5 and 6, 2, 3, and AVF. V1 through V4 and AVR one more time to make sure I'm not missing a STEMI, because some days have been really way too long, right? So let's look at this one. Too fast, too slow, or okay? It's okay. It's fast. I agree. It's fast. It's over 100, but it's not too fast, right? So that's me after I drink a Monster. It's 107. That's cool, right? If I'm getting to 140, 150, we got problems with that, though. So rates okay-ish. I'm going to look at injury patterns. I'm going to look at leads 1, AVL, 5 and 6. We got some T-wave inversions, right? 2, 3, and AVF. QRS looks wide, but doesn't look scary. V1 through V4, I got elevation in V1, V2, a little bit in 3, right? Then I got some depression here. That's just one lead, though. So then I got to look at AVR, 1 and AVR opposite. So is this a STEMI or not a STEMI? I said yes. I said STEMI or not a STEMI. They say yes. I don't know what that means. Sweet. Let's see if I got it marked now. Yeah. So remember, after we get through looking at everything, I'm going to go back here and look at lead 2. My PR interval is a little bit long. My QRS is wide. So now I'm going to go back and look at V1, right? So now I'm looking to see if this is a left bundle or a right bundle, all right? So I have a Y complex QRS. So that tells me there's some kind of delay there. So a bundle branch block, I go to V1. This points down. You got a big Q wave there. So that makes me think that it's a left bundle branch block, right? Now, most of the monitors, when it says left bundle branch block on your life pack or your Zoll or whatever you're using, it's going to quit interpreting. It's not going to say STEMI or no STEMI. It kind of jacks it up a little bit. So here's where we got to figure out what's going on. There's something called Scarbosa's criteria that you can use to determine is this a STEMI or not a STEMI, right? What causes a left bundle branch block? Anybody know? Heart enlargement. Yeah, the bigger the heart gets, it slows that conduction to the left side of the heart. QRS gets wide, right? So congestive heart failure, people with chronic heart disease that had STEMIs, people who have been smoking a little bit too much crack for too long, right? You get cardiomyopathy, things like that will cause that. The way you define it is you got a QRS complex greater than 120, a Y QRS, right? And then you're going to see a downward deflection in V1, all right? Cool. We use Scarbosa's criteria to determine if this left bundle branch block is concerning for a new heart attack or not, okay? So the way I remember it is discord is good, right? Anytime you got ST elevation that's concordant, ST elevation in the direction of the QRS complex is bad, all right? Either going up or down. Discord in the left bundle, as long as it's less than 1 big box, you're okay. So discord is fine with that. So on this one, we got ST elevation V1 through V4, but it's discord. So when really this one is not super concerning for a new STEMI. It's a left bundle, but it's not concerning for a STEMI. So if I saw this in the ER, I'm gonna say, yeah, it's a left bundle. There's no Scarbosa. I'm still gonna work them up for heart problems, blood tests, do all that stuff, right? But it doesn't make me think big freaking STEMI. Does that make sense? All right. Now, if I have somebody that's in the early 40s, 50s, even 60s, no history of heart problems, that comes in diaphoretic, chest pain, hypotensive, looking like dirt, and I have this EKG, this could still be a acute coronary syndrome, right? This could be somebody who's gone from a normal looking heart to having a big freaking MI with damage across the whole left side of the heart. So this can still be something that needs to be cathed, all right? But for the most part, left bundles that don't have Scarbosa are okay, all right? All right, well, this one, too fast, too slow, or okay? Okay, that's the easiest question. I should get that one. That one's easy. Yeah, it's okay-ish. I'm gonna look injury patterns, 1 AVL and lateral. Nothing super concerning. 2, 3, and AVF are my inferior leads. I got some ST depression, T-wave inversion there, not a STEMI, but it's concerning. The next thing I'm gonna do is I'm gonna look V1 through V4. And what does this make you think? We're looking for elevation we don't see, but we see this. So that makes me get kind of sweaty, right? So that looks abnormal, makes me uncomfortable, right? So that would be a posterior infarct in most folks, right? So I'll look at that. Next thing I do is I go back to AVR. 1 and AVR are opposite. That's good. There's not much elevation in AVR, all right? And the next thing I'm gonna do is I'm gonna go back and I'm gonna look at my intervals. So I go to lead 2, PR interval is okay. My QRS is wide, so now I have to go to V1. And at V1, I see I point down, right? Excuse me, point up. The QRS complex points up. So this makes me think of what? A right bundle branch block, okay? Now, this is a little bit deeper than we normally go with 12 leads, but it's important, and it's important because that first EKG I showed you, and it's pretty important because years ago, we couldn't fix STEMIs. We told people, yep, you're having a heart attack. Here's an aspirin, here's a blood thinner. I might hang some lidocaine for you, so if you go into VTAC, you don't die, all right? But we can actually intervene on these things now. There are thrombolytics we can give. We can do heart casts. If somebody has bad issues, we can do other procedures for them to help them. So it's pretty important to understand the left bundle and the right bundle now. That's now basic 12 lead, guys, unfortunately, right? So I look at V1, QRS complex goes up. This is a right bundle, all right? So what things cause a right bundle? Anybody know? Same things that cause a left bundle, heart problems, right? But it's the right side of the heart. The things I think about more likely, people who have chronic pulmonary problems, so people with pulmonary hypertension, people who smoke, or people who have had a PE or having a pulmonary embolism. You'll see a right bundle branch block because you get increased right-sided heart pressures, so the right side of the heart gets pretty jacked up. So with the left bundle branch block, if this is a conduction pathway, the left bundle, chronic hypertension, underlying heart disease, the left side of the heart gets, so it slows conduction to the left side of the heart, so you get a left bundle branch block. All right, somebody who has chronic hypertension and a left bundle branch block, eventually the right side of the heart gets bigger as well, and you get right-sided heart failure, all right? But acute right bundle branch block will be somebody who has pulmonary hypertension, a big PE, or chronic left-sided heart failure. Everybody still awake? Sort of, kinda? I didn't put any inappropriate slides on this lecture. I forgot to put my inappropriate slides. Sorry. So just a schematic that kind of looks at the way we look for ischemia. So 1 AVL, 5 and 6 are your lateral leads. 2, 3 AVF are inferior. V1 through V4 are your left main coming down, big portion of the heart. And then both the right and left coronary come off the aorta. So if you get ST elevation and AVR and depression anywhere else in an pattern, it's concerning for a big bad disease, right? So this is super basic 12 lead now, right? And now we got to start looking at left bundles and right bundles. The only way to get better at these is look at a lot of them. There's no way you're going to get it. This is the first time you heard it from me. So Wave Maven is a great app, web page. Life in the Fast Lane is an EMS geared 12 lead interpretation class. There's all kind of things out there, all right? But the only way to get better is look at a lot of these. And it makes a difference in the patients we take care of. So let's go back and look at this one. So we said this rate was okay. I look at 1 AVL, not super concerning. 5 and 6, maybe a little bit here in 6, but it doesn't make me scream STEMI personally. 2, 3 in AVF, right? I look V1 through V4, right? I got some, would y'all call it elevation? Yes, no? Yeah, elevation there, elevation in 3 maybe in 4, right? I don't see any big depression, right? And then I go back and I look at AVR, excuse me, yeah, right? So, and then the last thing I'm gonna do is go back and look at interval. So I go back to lead 2. Your interval looks okay. QRS, a little bit wide, right? It's 132, all right? So now I'm gonna go over here to V1. In which direction does that point? Points up, right? So this is a right bundle branch block. So with the right bundle, we should have depression here. We should have that deep T-wave inversion, all right? Which is not concerning, but instead, what do I have? Elevation, right? So this one, did the machine pick it up? No, right? So at first glance, if you look at this and you're thinking about, oh, it's the left bundle, it's always a little bit elevated there, not a big deal, you're gonna miss something, right? So that's why you gotta be pretty concise and understand these things. Had this been missed, this patient may sit on the wall for a couple hours, but it wasn't missed. So this is a big catch by the medics that took care of this patient. So this is a big freaking STEMI. With this right bundle, this should be pointing way down. So we're having pretty big infarct over a big portion of the heart, probably a bad outcome if we miss this. Does that make sense? Cool. So I want to say that about 25%, 30% last quarter of all the STEMIs that were put into BRIMs that the medic called in and thought they were a STEMI, but the machine didn't say it, were positive. The quarter before that, we even had more than that one. My point to that is, you guys are doing a great job already, but we got to do better. Okay, we got to better recognize these things. Just because it doesn't say STEMI doesn't mean it's not a STEMI. How would you put this in the STEMI system? You get to a hospital with a cath lab availability. What would y'all do? Call TCC. What are you going to tell them?
Yeah, I remember the EKG was like a dove, looks like a one.
Right. Yeah. They're going to say, does it say STEMI? And you say no, but I'm concerned. Right. Right. EMT discretion. It's a STEMI. They hook you up with the cath lab hospital. You send the EKG. The doc will look at it. If the doc agrees, great. You're in the system. You go straight to them. If the doc disagrees, who cares? You still think it's a STEMI? You still go to that cath lab hospital. You don't go somewhere else because you think there's a STEMI, right? If you go to another hospital that you didn't talk to, that's not a cath lab hospital, and you show them this EKG, now they got to go somewhere else, right? So if you're concerned enough to call TCC and say it's a STEMI, go to the hospital that you call and want to go to the first time. Does that make sense? Okay. All right. Cool.
Hey, Doc.
Yes, sir.
So I got a couple of questions to try to catch up a little bit.
Oh,
The
sorry.
last one is regarding bundle branch blocks. The question reads, do we no longer use B1 and B6 to check for bundle branch blocks? Example being deep wide QRS segment in B1 and tall notched R wave in B6.
Yes, you can still do that. Yes. So there are numerous ways to determine left bundle or right bundle, all kind of criteria. Different docs look different ways. The way I remember is the way I told you. All right. I can go back and relearn that stuff, but I use the 12 lead as a screening tool. So if there's enough data there to make me uncomfortable, that's the way I'm going to read that. So if you want to learn the more complicated pathways, to interpret those, that is fine with me. I got no problem with that. Okay. But that's the way I remember them. Cool.
The other one's back to the protocol. With regards to everything being Cat A, the question is, then why do we still have cardioversion and decompression Cat B? And I actually don't think they are listed as Cat B, but.
So I think the Cat B procedure list is still on the state webpage. But that's been incorrect for a while because chest decompression was Cat A like a year and a half, 2 years ago. So that stuff should be updated at some point soon. And remember, the 10th edition protocols are not active right now. They're up there so you guys can start looking at them, reviewing them. If you have questions, reach out to your medical director or to the state office, okay? But they're not active just yet. Cool. Sweet. So we say STEMI, right? Perfect. So what do you do? We talk about this a lot. I won't beat this one down today. I want to go look at a few other EKGs. Most important drug for this person is what? Aspirin, right? What if they said they took an aspirin before you got there? What do you say? Have another one, right? Right. What if they say I have gastric ulcers, I can't take aspirin? What do you say? Say, hey man, I think you're having some heart issues that could be pretty bad if we don't treat this. One aspirin won't kill you, all right? But not taking it may be a bad outcome for you, all right? I wouldn't say you're going to die. Give you the aspirin, it might stress them out, right? The only person I want to give aspirin to is if they have anaphylaxis to it. What about oxygen? Do they need oxygen? Yes or no? They're breathing 14 times a minute. SAT's 99%. So I would say yes. I don't give them supplemental oxygen. I'm giving them pre-oxygenation because high risk for decompensation, high risk for VTAC, VFib arrest, or going into cardiogenic shock. So a couple of hours of O2 is not going to hurt somebody, all right? Do they actually have to have it right now by ACLS or American Heart? No. But if you got one or two guys in the back of a truck and the guy starts crashing on you and you already got him on a 12 liters nasal, you can crank it up to 15 liters and you got passive O2 going on right there, okay? If you get to the hospital and somebody fusses at you, you smile and say thank you for the information, all right? And don't worry about it, in my opinion. Cool. Nitro, what does nitro do? Vasodilation, right. What if its blood pressure was 90/60, does it get nitro? No, perfect. What if it's 110 over 60, does it get nitro? Sure. Do you start an IV first and have IV fluids hanging? Perfect. What if he's having a big inferior right side elevation of leads 2, 3, and AB. What if his blood pressure is 160/80 and he's got an inferior? So don't be concerned about the inferior. You recognize that they're having an inferior infarct and you give them nitro, there's a risk you decrease their preload and drop their pressure. Okay, but if they're not hypotensive or bradycardic to begin with, and they're sitting there clutching the chest pain, sure, pop a nitro. If they drop their pressure, what do you do for them after you cut? Yeah, fluid bolus. Right. Good. Yeah. Sweet. What can you use fentanyl in cardiac disease for chest pain? You can. It makes them forget they're having pain. Doesn't do a lot for you. Morphine lowers blood pressure, is also a vasodilator, so it may be useful. So morphine is reasonable. What about ketamine? Can you use ketamine for pain in cardiac patients? Say no. No, you don't want to use ketamine. Increases blood pressure and heart rate. It also makes them trip, right? It may bother them too, but the hospital. So no ketamine for your heart attacks.
Got another question if this is a good spot. Doctor.
Sure.
So since American Heart Association recommends printing 12 leads in Cabrera format rather than standard layout, how do you use AVR since the polarity is reversed? And I don't understand that question, but I was hoping you would.
No, sir. No clue.
All right.
That one is going to be a Google search. I'm not sure on that one. Sorry. I failed you. Any comments, doctor? No. Yeah, I don't know. Sorry. Yeah. Right. Remember, things that kill people in STEMIs or acute coronary syndrome early on is VTAC, VFib arrest. So all the patients that I take care of having a STEMI, they get defib pads on. Not every chest pain patient, because you'll go broke, right? But they're having a STEMI, they get defib pads on. That way, if they do go into cardiac arrest, all you got to do is put your cigarette out, charge the 200, and defibrillate, right? And it's none of this calling people names, screaming, pulling the truck over, putting the pads on, putting the oxygen on, starting CPR. So just like everything else you do, prepare for the worst so that things go well as they can, right? So this patient, this patient got one shock back into a sinus rhythm, didn't get CPR, didn't get tubed, didn't get anything, showed up at our ER and went straight to the cath lab, and a good outcome. Just because the medics were proactive, had them set up, watching for the things that we can take care of. All right. All right, the second case, because the second case always gets a little bit cheaper beer, right? Going downhill. Yeah, that's good. That's still a good beer, though. So I'll let y'all look at this EKG and see what you think about it, and we'll talk about it. So the first question would be is, does it make you uncomfortable? Yes or no? Yes.
First question is, do they have a pulse?
Correct. So the first question is, why'd you get a 12 lead on somebody with a heart rate of 20, right? Right. That goes back to we should be taking care of the patient, because I bet you my $3 they don't look good, right? So, what now?
He does CrossFit.
CrossFit, yeah. Really? Yeah, that's not CrossFit, sir. So management, obviously, ABCs. Show up, the patient is talking to you, they look ill. I'm gonna kneel down, get a quick pulse, somebody go and put them on the monitor. I realize that my ADHD kicks in and it takes way too long between the beats on his wrist. It makes me uncomfortable, right? So we're gonna start an IV, get a quick AccuCheck. Why would I get an AccuCheck on somebody with a heart rate of 34? Do what now? Yeah, right. So if I get a quick AccuCheck, right, and his glucose reads high and he has a low heart rate, what's causing this probably? Potassium. He's hyperkalemic. So I've just kind of diagnosed him right there, right? Okay. Now I'm not going to send somebody back to the rescue to dig for the glucometer and wait 20 minutes for her to do anything, right? But if it's there, I'm getting it, right? So hands on the pulse, getting the quick set of vital signs, heart rate of 34 on my 3 lead. He's altered and diaphoretic. What am I going to do for him first? Give me some atropine. Yeah, atropine, low risk, right? What if he's in complete heart block? Will atropine help him? Nah. Will it hurt him? Can you find your atropine in your drug box pretty quick? Yes. Yeah, it's an easy one to give, right? You pop it open, you screw it together, and you push it. So one of atropine, if that fixes him, great, right? Then you start your second IV, then maybe you get your glucose checked. Start thinking about packaging him up, moving to the hospital, right? If atropine doesn't work, what are you going to do? What now? Pace. Oh, cool. Can you pace right now in the state without calling a doctor? No. You can starting in April though, right? Yeah. So that's going to change everything, guys. You got to be sure that you know how to do that and know when to use that, because you don't have to call. And I think that's very reasonable for things like this, right? Pacing is quick and easy, right? What if, what medicines could you use before you pace this? Get him out of it without using electricity. So I would do calcium. Yeah, so slow and wide, I always give a gram of calcium. There's no risk and potential benefit. Now, I'm not going to give 6 grams of it, right? But 1 gram, if it gets better, high five my partner, it's a good day, right? What else can you give? Dopamine. Some places don't. How would you give the dopamine? Open. So it's a you prime it through the line, you hook it up to the IV fluids, and you open it up, and you give about a minute to get there. And as you're giving that medicine, you're thinking about what I'm going to do next. Maybe I'm planning my next drug. Maybe I'm getting my pacer pads out. Maybe I'm thinking if I'm going to pace the guy, I may have to sedate him and intubate him at some point too, because no, people don't like being paced. Okay, they cuss 60 beats a minute, right? So dopamine's going in. Give it a few minutes. If the heart rate increases, great. Slow it down to what dose would you give? Yeah, so what's the dose of dopamine? Total dose you could do. Yeah, so 5 to 20. I start at 10, right? When you get above 10, you get more blood pressure effects than heart rate, but 10, right? I give the dopamine. It doesn't work. I'm still going to keep it going, though. I'm going to slow it down, set it at 10 mics per kilo per minute, and then I'm either grab my pacing pads or another drug. What other drug can you give? Epi. So you can do push dose Epi, or you can start an Epi Infusion, okay? Are y'all doing push dose Epi? Anybody doing that now? Cool. So I would advise that if you're going to do push dose Epi, make sure you mix it up correctly and know how to do that, so you're not doing it at 2 o'clock in the morning, right? Do not give 1 to 10,000 Epi push to somebody that's alive. We'll call it feedback, right? Do not give 1 to 1,000 Epi anytime. You will cause death, right? So make sure you do that. Cool. Perfect. So let's go back to this 12 lead. So what's going on with this guy? Too fast, too slow, or okay? We already said it's too slow. I do the same thing every time at a 12 lead, so I don't miss something bad. I'm looking for injury patterns. I only got 1 beat to look at though, right? 1 AVF, 5 and 6, 2, 3 and AVF, excuse me, 1 AVL, 2, 3 and AVF, V1 through V4, go back at AVR. I'm gonna go back, look over here, look at my peer interval. It looks okay there. QRS, a little bit wide. Yeah. So what kind of rhythm is this? What is this? You can say slow. I'll take that. Yeah. What'd you say? Yeah. So I say this is these are junctional beats. Technically, if you want to say left bundle, you might could say that. But I say this is probably more an escape beat, a junctional rhythm. What are these dudes here? Bloop, bloop, and bloop. Yeah, yeah. So I got 3 P waves and 1 QRS. So what is this? Yeah, I'll call it complete heart block. Does it matter? Is it secondary type 2 or complete heart block? It's the same, right? Now, like you mentioned, atropine. I would still use atropine on this the first time, because even though textbooks say atropine is not going to increase conduction through the AV node, some people's bodies don't know that. So sometimes atropine will work on these people. Usually does not, okay? Cool. So this was a guy that had recent heart surgery and came in, heart rate in the 20s, mentating appropriately, blood pressure like 80 systolic, all right? Would you pace that guy right off the bat? He's awake, alert, blood pressure of 80, mentating appropriately, playing Panda Pop on the phone. Probably would not pace him. You could now, right? Everything's going Cat A, you could pace him. But I would say that he's compensating okay-ish, right? He's mentating. So this is the guy that I would try medicines first before I start putting electricity on him. Now, his pad, I put pads on this guy right off the bat, because if it goes downhill, I turn the pacer on. I capture him. But this is somebody I would do the atropine. I start some dopamine. I actually gave him some Epi Infusion and wanted to do that before I started pacing this guy. But I recognize he's sick as dirt. I'm standing there right with him, and I'm working my way up. I will not go straight to pacing with this guy, even though American Heart says complete heart block, you go straight to pacing. Because now, if I got a 45-minute transport and I'm going to pace this guy for 45 minutes, he's not going to appreciate that, right? Most people that I have to pace are self-sedated, poor cardiac output, poor perfusion, they're altered. I look at him, heart rate's 20, he's not saying anything or just moaning, screw it, pads are on, it was starting the IV, I'm turning the pacer on. As he wakes up, I may start dopamine and maybe get the pacer off of him. Or if that doesn't work, I got to think about giving him some pain control and then be concerned about airway management. Correct. I mean, yes, sir. Right. Yeah. Clinically appropriate. Right. And clinically is not one set of, now the 23 heart rate should make you be sweaty, right? And you got to be prepared. But if he's mentating, I'm not going to go straight to pacing. Does that make sense? Pads are going to be on him very quickly. Yes, pads are going on as I'm starting my IV, and then I'm pushing the atropine and going to dopamine, right?
For your pain management on that patient?
Yes, sir.
Fentanyl or?
Fentanyl's fine. Yeah, it's not going to lower blood pressure, so fentanyl's reasonable. I wouldn't do ketamine just because it's going to alter him too bad, I think. Bert said maybe reasonable. Ativan, if you carry Ativan, the state says you can carry Ativan. Ativan's a great drug, doesn't lower blood pressure. Fentanyl's probably the best drug for that dude. Yes, sir. Right. So this is him. So we gave him some atropine, put the pads on him. He was still hypotensive but mentating. Started some dopamine. He got it up to like 15 mics per kilo per minute. It wasn't working. So we started the Epi Infusion. And you can do it at 2 to 10 mics per minute. I usually start it like at 1 or 2 and just double it until I get response. And after about 4 minutes, I got this. So much better. Now he's like, oh, I don't feel so tired. Well, good. I'm glad you don't, sir. Right? And then you can kind of wean the epi back down as well. These drugs are titratable, easy to do. Now, I've seen people with that same heart rate in the 20s be given epi 1 to 10,000 by mistake, and you occasionally see them go into VTAC, right? If they go into VTAC with that and they have a pulse, what are you going to do for them? It's a trick question. After you cuss, wait it out, right? Yeah. If you give them amio or lidocaine, when the epi wears off, whatever ventricular activity they had is now gone. You're going to make them worse. If you shock them, they're not going to appreciate it because it's not going to fix it because they just got a big dose of epi, right? Now, if you push that epi by mistake and they go into VTAC and don't have a pulse, you're hosed. The patient's hosed. Defibrillate, CPR, go down that pathway, all right? But if they still have a pulse, I'll let it ride out. That being said, just don't give the wrong drug, right? All right, thank you for almost smiling. All right, last case. All right. Too fast, too slow, or okay? It's okay, yeah, okay. Injury patterns, I'll let y'all look at 1, AVL 5 and 6, 2, 3 and AVF, V1 through V4. Look at AVR. And now I'm gonna go back and look at my intervals. Like, man, I'm not really sure where my POAs are, but QRS is okay-ish. So what do you think about this EKG? Concerning or not concerning? Very concerning, right? So with no history, and I see this, I think posterior, that's a STEMI. All right, I can also go over here, look at AVR. I'm up in AVR, and I got depressions all through here. So I think big infarct way close to the left main, right? In reality, this was a post-cardiac arrest patient. So this is somebody that was walking through the front yard, talking on the phone, and then just kind of passed out. Didn't have a pulse. Bystander started CPR. EMS got there, slid an eye-gel in, drilled him, gave an epi, put him on a Lucas, and brought him to the hospital. So this is a post-arrest EKG. So this could be from a VTAC, VFib arrest, a big STEMI that went bad that we got back, or it could be from the fact that dude was dead for 10 or 15 minutes and his heart's jacked up. But it's very important post-cardiac arrest to get a 12 lead. It gives us a lot of data. If I have this EKG, I have more of a chance to get that patient to the cath lab. So if it was a STEMI event, we can get that fixed, okay? So post-arrest patients, so you get on scene, you slide an eye-gel in them, you defibrillate, push an epi, now you get ROSC on this patient. What things do you want to do on scene before you transport them? 12 leads important, give them the STEMI system. I hope that one day we have a resuscitation center or centers where every place can go. You can get a cath lab, you can get ECMO, you can get hypothermia, and get all the post-arrest care. We're getting there. COVID's kind of slowed those things down, but 12 leads is important. What else you want to do with somebody? I hear ramblings. Vital signs, yeah. So blood pressure with this, heart rate's in the 70s. Dude's not breathing much on his own. Blood pressure is 80/40. Sats are 92%. End-tidal is 60. What are you going to do with that? Give him some fluids. Yeah. All right, fluids. I like that. What else can you do for this guy? Maybe some push dose epi, maybe a little bit. He's a little bit hypotensive. I'd be a little bit concerned if it had a VTAC arrest. Before I start giving him epi, I'd probably do some fluids first. Another drug you can give this guy, some dopamine potentially. Okay. All right. I'd probably get an AccuCheck on him at this point if you haven't done that. I would make sure your IV access is secured. If he's just got an IO, maybe somebody sticks an EJ in. Make sure you tape those down. All right. If he doesn't have a gag and you're having trouble ventilating the guy, I got no problem with you pulling the IGL and intubating him. If the IGL is working, leave it alone. But if it's not working, change it out if you're a medic, okay? Remember, even with IGLs, you got to have waveform capnography if you're ALS to confirm placement, and that's got to be documented. You got to have a numeric, all right? Definitely with ET tubes. Cool. Questions, comments, statements within reason. I know there are a lot of things going on. The hospitals are full. Most every ER in our region is boarding patients. There's some days that the ERs have just 1 or 2 rooms open to take care of critical people. I get it. The healthcare system is in a bad spot right now. So we still got to take care of people. There's still things that we can fix out there. If you get to a hospital and you have a patient that makes you uncomfortable, you're concerned about them being sick, unstable, a STEMI, a stroke, a trauma, a bad GI bleed, and you're not getting the response you need, go find the doc at that hospital and tell them, I'm concerned about this patient, come take a look. They should come look at that patient for you, okay? If they don't, reach out to me, okay? We can't let people sit on the wall that are sick, all right? The discussion about how long do you stay in a hospital and wait, that's gonna be an agency by agency, what your community decides is appropriate. The state has said that you don't have to wait on walls forever. You have to get back and take care of the people in the community that you work for, right? But use common sense. If you got a patient that's sitting there on BiPAP or high flow O2, you can't take them and put them in a lounge chair, right? But find that doc, let them know that patient is sick so they can work with you. I can tell you that the physician groups that I've talked to in this area want to do the right thing, but they're overworked and understaffed just like we are. Okay, but we can't let people die from things that we could have fixed 2 years ago. Questions, comments, statements about protocols or anything else? Oh, have I shown those pictures? I can't remember if I've shown those. You don't know? These are some cool toys, man. These are at Five Below. Y'all been to Five Below? Oh, good. Y'all must make more than me if y'all don't go to Five Below. Five Below is great. This one's cool because the doctor's got bigger arms than the EMT. That's why I like that one. That's me. Sweet. The point of this slide, and yes, the continuous transformation, yes, sir, in the other direction. The point of this side is I got 3 rules that I try to live by. One is don't kill people, right? And that means that understand the medicines I'm giving, the skills that I'm doing, the procedures, and I know how to practice within my scope of practice. If somebody came into the hospital and they had a head bleed, a subdural hematoma, I cannot fix that. If I take you to the OR, you will die, no matter what the problem was, right? But I should recognize that that dude's jacked up, has an altered mental status, and I think he has a subdural hematoma, and I should be able to get that neurosurgeon on the phone. Just like you guys should better recognize, oh, that's the right bundle, but that's a freaking STEMI. I need to get to the hospital and get a cardiologist, all right? I do what I can to help people. That means that I train well, I work hard, I'm up to date, I'm always training, and then I go home with a clear conscience. In the same way I do that is I make sure that I'm conscientious, I do a good patient assessment. Sick people, I expose, I work them over. I try not to get too jaded and burned out when I got sick people in front of me. So this is EMS, right? If this is EMS, what now? Yeah. So saying that EMS is providers, medics, or healthcare workers is kind of a joke. You're more than that. That's like calling that guy a day laborer, right? So you're out there taking the brunt of all this stuff. I appreciate what you do. All right, now questions, comments, statements within reason. I got 3 minutes.
Question.
Yes, sir.
When will IMSA place the fast scale as far as?
Excellent question, sir. I'm not sure.
Okay.
It keeps getting pushed back. Yes, sir. Yeah, I don't know. The date keeps getting pushed back. Lots of things are getting pushed back. Unfortunately, everybody is, there are staffing issues everywhere. Hospital, ADPH, everywhere's got staffing issues. Things are just getting held back. Other questions?
So I'm Julie Brown, for those who I haven't met. I'm one of the EMS fellows at UAB. So I'm an ER doctor at UAB right now. I'm just doing an extra year of training in EMS. Today we're going to talk about immunologic emergencies, but what that means is allergic reactions, things like anaphylaxis, okay? All right. Oh boy.
What did you do?
That wasn't me. Where's the X?
There you
All right.
go. That was close.
All right. So allergic reactions or immunologic emergencies, things like anaphylaxis, urticaria, which is just hives, and angioedema are really common complaints that can be encountered by EMS. They can have various triggers, things like different medications, antibiotics, poison ivy, poison oak, insect bites, wasps, hornets, things like that. Lotions, laundry detergents, dish soaps, and the severity can really vary from life-threatening emergency to really just kind of a local rash. So we need to be able to recognize when anaphylaxis is happening so that we can treat it appropriately. All right, so these are the things we're going to talk about. The pathophysiology, we're not going to get down into the weeds of it, but just so y'all know why we're giving these certain treatments, the signs and symptoms and treatments for hives, anaphylaxis, and then we'll talk about angioedema at the end. So we're going to start with a case. So you get called out to a 25-year-old who's eating at a local seafood restaurant. He's complaining of itching. You get there, he's a little bit anxious, kind of scratching his arms and his legs. And then you start asking him his history, and he says, oh, I'm allergic to shrimp, and my friends ate shrimp, and then I ate something off their plate. Doesn't really have any other symptoms. And why are we wondering if he has other symptoms?
You think it's a moderate severe response.
Yeah, so we wonder, is this just going to be like a skin rash, like urticaria or hives, or is this going to progress to anaphylaxis? These are his vitals. His heart rate's 102. Otherwise, everything looks okay. So we're going to talk about hives, and then we'll kind of come back to this case, okay? So urticaria or hives is just like welts or wheals on the skin. About 20% of the population will get this at some point in their life. It can be triggered by really anything. You might find the trigger, but a lot of times you probably don't. And this is just kind of the picture is just the welts or the wheals, the hives that you'll see. So what these are just kind of transient, meaning they come and go, really itchy, raised red lesions. They can be very variable in size and shape. They can coalesce when they get bigger, which means that as those lesions get bigger, they all come together as one, and they just form one big lesion, is what that means. Any area of the body can be affected. So areas where your clothing is compressing your skin can be more affected, or areas where your skin rubs together. Think like axilla can be worse. They're not really painful, they're just itchy, and that itchiness can be more severe at night. So what causes urticaria or hives? So it's going to be a reaction that's caused by mast cells or basophils, which are just cells that are in your skin. And what happens is you get exposed to some allergen, something like a food, like a penicillin, some sort of lotion, and your body makes an antibody against that. That antibody will bind to these mast cells. I'll show you a picture. So you're exposed to an allergen and makes an antibody. That antibody will bind to these mast cells in your skin. And then once you get re-exposed to that allergen, that antibody will cause the cell to release chemicals. And those chemicals are like histamine, which we'll talk about, It can cause other vasodilators, which are just going to cause that swelling in the skin to get released. But that's just kind of the basis of the pathophysiology of it. So then what does histamine do? Because a lot of medications we use for hives, for anaphylaxis, can be antihistamines, things like Benadryl. So histamine can cause bronchoconstriction. It can cause your blood vessels to dilate. So that causes that localized swelling in your skin. It can cause your heart rate to go up. It can cause your cardiac output to go up. Gastric acid secretion is what it can cause, and a couple of other things. But those are the kind of the basis of the things that we would want to treat with the medications that we have. So we talked a little bit about this. So what causes hives? Things like antibiotics, most commonly penicillins. A lot of people are allergic to penicillins. You think amoxicillin, augmentin. People can be allergic to like Keflex, which is a cephalosporin. Bees, wasps, hornets, really kind of any flying insect. Different foods, milk, eggs, peanuts, tree nuts, soy, latex, if you still have latex gloves. And then something we don't think about as much are transfusion reactions. So if you're doing like an interfacility transport and the patient's getting blood and they start having a skin rash, you can think, oh, maybe this is urticaria hives, and start worrying about maybe this is going to progress to anaphylaxis. All right, so what do you want to know? So you get on scene to this patient who's itching after they got exposed to a seafood or they got exposed to something that we don't know. Are they having any other signs or symptoms? Are they just having a rash? Are they having like shortness of breath? Are they having vomiting? Are they having diarrhea? Are they wheezing? Is their blood pressure low? Have they ever had these symptoms before? So if they have an allergy to peanuts and they eat peanuts, this has probably happened to them before, right? Is there an obvious etiology? Did they ingest something they shouldn't have? Did they get a similar reaction to a lotion they've used before? And then just look at the lesions. So treatment. So most of these are going to be just hives or just the skin rashes are going to be self-limited and they're going to go away on their own. You can give medications just to relieve that itching, just to make them feel better. So you can use H1 blockers, which is going to be like Benadryl. It's going to be a little sedating, so they'll be sleepy afterward. So you can use 25 or 50 IV or IM. If it's not very significant, if the patient has PO Benadryl, they can take that. H2 blockers, things like Pepcid. Zantac was an H2 blocker that got taken off the market, but that's another one you can use. And then sometimes if they go to the hospital, we might give them steroids. They probably don't really help, but it might kind of, if they have prolonged symptoms, it might suppress that inflammatory reaction. All right, so back to the case. So we had this guy who is allergic to shrimp and ate off his friend's plate who had shrimp. He's a little anxious, he's itchy, but really doesn't have any other symptoms. You look at his arm and it looks like this. So what would y'all want to do with him? Not having any other symptoms. Yeah. So we're going to give him some Benadryl. He gets a little better, but he's not all the way better. And he's like, just take me to the hospital. All right. So now he's complaining of throat tightness. So now what? Say that again. Yeah, oxygen and epi. So now we're worried about what? Anaphylaxis, yeah. So now you repeat his vitals. His heart rate's 130. Like, oh no. His O2 stat's 95, and he's wheezing. So now we'll talk about anaphylaxis, and then we'll talk about the treatments. So anaphylaxis has a lifetime prevalence of about 2% in the US, so about 2% of people are going to get anaphylaxis at some point. It's obviously a very serious allergic reaction. It can happen and start occurring very rapidly, but the diagnosis is really just made on the signs and symptoms that you see. And we really need to be able to recognize it. Okay. So to diagnose anaphylaxis, there are really three diagnostic criteria that you can use, but the basis is that if a patient has a suspected exposure to some allergen and they have symptoms in 2 or more organ systems. So say they have a rash, 90% of people with anaphylaxis are going to have a rash, and they have shortness of breath, then that's anaphylaxis. If they have a rash and they have vomiting and diarrhea, after they were exposed to like a peanut or something else, then that's anaphylaxis. Or if a patient is exposed to a known allergen, so say they have a peanut allergy, they went to, some restaurant that has peanuts everywhere, or they went and ate at Chick-fil-A, and their blood pressure is low now, you can think this is maybe anaphylaxis, okay? And they might not have any other symptoms yet, but we prefer to treat it early. Yeah, so that's what this is. So some patients aren't going to have symptoms in 2 or more organ systems, but you still might be appropriate to give epi. So the person who has a history of severe anaphylaxis to peanuts, who is exposed to peanuts and they're itching, you might want to go ahead and give them epi because they're probably going to progress to a more serious reaction. Sorry, that didn't show up very well, but it's the same pathophysiology as urticaria or hives. You get exposed to an allergen for the first time, it makes antibodies against that allergen. When you get re-exposed to it, those antibodies on your mast cells or your basophils release chemicals like histamine and other chemicals that cause the symptoms of anaphylaxis. So the different signs and symptoms, so on the skin, you can get hives, itching, flushing. You can think of like angioedema, like a swollen tongue, swollen lips, periorbital edema, so swelling around the eyes. You can get, respiratory-wise, you can get itching of the throat, itching of the ears, shortness of breath, wheezing, cough. Then you can think like nausea, vomiting, diarrhea, or like a crampy abdominal pain. Or the patients might get hypotonia, meaning they don't pass out, but they just kind of collapse because their blood pressure gets low. Syncope, incontinence, dizziness, tachycardia, or hypotension. Those are all kind of on here. So think like respiratory or airway problems, skin problems, GI tract problems, and then did they pass out? Is their blood pressure low? So more kind of brain and heart. So anaphylaxis is really unpredictable. It can really be kind of a mild localized reaction, so they might just have that skin rash, or it can really get bad, and these patients their airway can close, and they end up intubated in the hospital in the ICU for days on epi drip. It's really impossible to predict how severe it's going to become, how rapidly it's going to progress, and then whether these symptoms are just going to be severe for a minute and then go away, or if they're going to kind of last a couple of days. So death from anaphylaxis is usually from asphyxiation or cardiovascular collapse, and it can occur within minutes. So I found this interesting. There's a study that was done, or it was a case report that looked at, I think, 164 patients, and they looked at the median time interval between exposure to an allergen and how long it was until they had a cardiac arrest or a respiratory arrest. And they found that patients who were allergic to like an IV medication, contrast dye, or like an anesthetic, like if they're in the operating room, it was about 5 minutes. So think if you're in a hospital, you're about to do a transport for a patient and they're getting a medication and then they start itching and become short of breath, it might not be very long before they lose their airway, okay, or they arrest. For insect bites, it was about 15 minutes. And then for food-induced, it was about 30 minutes. So think if you're in a hospital setting doing a transport, or you give them something in the back of the truck, you probably don't quite have as long to treat them as if they were ingested a food or something.
So when you say food-induced, is that also like a oral medication? Any
Yes.
ingested?
Yeah, because I think like an IV medication is going to get in their system a lot quicker than one that goes through your GI tract and has to get digested first.
Hey, Doc.
Yeah.
So it's interesting to me that circulatory collapse is kind of ranked right up there with airway compromise for cause of death. So how important or how effective is fluid bolus to prevent circulatory collapse? Is that important for these patients?
I would think epi and IV fluids kind of at the same time. You can give the epi while you're starting an IV, or if you have a partner who can start an IV, get them to start the IV and give the fluids all at the same time. So we'll talk about that too in the treatments. So then just a quick thing on biphasic anaphylaxis. What this means is the patient had anaphylaxis, they got better, and now they're worse again, and they didn't get exposed to the allergen again, okay? This can happen about 5% of the time, and a lot of times it'll happen within 12 hours of their symptoms getting better, but it can last like 3 days, or it can occur 3 days later. So this patient might have been treated in the hospital, released, and then they call and they're like, hey, I feel like the same way I felt whenever I had anaphylaxis a couple days ago, but I haven't, eaten another peanut or used this lotion again. So there are a couple risk factors for bad outcomes with anaphylaxis. This, what you would think, anybody with respiratory disease, asthma, interstitial lung disease, COPD, those are all going to have worse outcomes because this is the thing that's going to kill these people is either cardiovascular collapse or an airway problem. And if these people already have very reactive airways, it's going to be worse. If the patient's on a beta blocker, like an ACE inhibitor, this can worsen their outcomes or worsen the severity of the anaphylaxis, mostly because their body's not going to be able to compensate quite as well. So think with the anaphylaxis, if they're on a beta blocker, their heart rate's not going to be able to increase as significantly as if they weren't. So for treatment of this, obviously focus on your ABCs. If they have an airway problem, we need to address it. Remove any inciting causes if you can. So if you're transfusing a medication in blood or like an antibiotic or something, try to stop that. Give them Epi, IM, not IV, and then start oxygen, get IV access, start fluids, and then put them on a monitor. So the Epi dose is 0.3 of the 1 to 1,000 IM. You can repeat it at 5 to 15 minute intervals. If you need to repeat it before that, that's okay too. A second dose is necessary in about 20 to 30% of cases. So that's something important to remember is like, oh, you gave their Epi, high five, they got better. 10 minutes later, they look like garbage again. And in patients that have had a history of anaphylaxis or a history of a severe allergic reaction, or if they come in with shortness of breath, they're more likely to need a second dose of Epi. So a little bit on what Epi does. So it's an alpha-1 agonist. So what that does is increases vasoconstriction, which means with the anaphylaxis, you have dilation of all your veins, right? So of your blood vessels. So this is going to constrict those to raise your blood pressure. It's a beta-1 agonist, so it's going to increase your heart rate, increase your cardiac output. And it's a beta-2 agonist, so kind of like albuterol, it's going to dilate your bronchioles and kind of decrease the inflammation that's associated with anaphylaxis. So things that Epi can do, it can cause people to be anxious, kind of restless. They might have a tremor afterward. It can cause ventricular arrhythmias. It can cause angina. It can cause MIs, less likely with an appropriate IM dose. But anaphylaxis can also cause these things in itself without Epi. So treat it. There are no absolute contraindications, but if a patient is like 85 and they have 18 stents and they've had a cabbage, they're more likely to have an adverse effect from the Epi. All right, so back to the case. So we had the 25-year-old guy had anaphylaxis to shrimp. He has a rash and wheezing, so we give him Epi. We get IV access, we give him some fluids. He's still short of breath later, so we give him another dose of Epi. But now he's hypotensive and he's altered. So what do y'all want to do with him now?
Yeah.
Say he got 2 liters. Yeah, for sure. So Epi is going to be the answer, right? So push dose Epi. If you're a little bit closer, if that's easier for you to do. If you have IM Epi or IV Epi infusion, you can also do that. I think if you have a shorter transport time, it's very reasonable to do push dose Epi. You just need to be aware of how much you're giving and when you need to give another dose. This is like an easy way to make an Epi drip, but obviously talk to whatever agency you're at and y'all figure out how you're going to do it if this is going to be the right thing for y'all versus the push dose Epi.
The problem is that neither one of those items are currently available in the supply chain.
Yes, that's what I said. Talk to your agency. and figure out how y'all are going to manage this. Because I think push dose epi is very appropriate. But if you have a 45-minute transport to the closest hospital, you're going to be pushing a lot of push dose epi, right? If they're pretty sick. So.
Is there any role for dopamine?
No, because it has different receptors. It doesn't act on like the beta 1, beta 2 that anaphylaxis is affecting.
What about epinephrine 1 to 10,000 IV?
So there is, I actually had that somewhere on here. Oh shoot. Oh boy. Oh no, we're good, y'all. We're good. Okay. Hold on, let me find it. So I didn't include this because I didn't want everyone to go out and give 1 to 10,000 IV, but you can give a slow Epi IV bolus. It's in the literature. It's recommended by UpToDate, but we really want to avoid it if we can. It has a lot of complications and there are a lot of dosing errors associated with it, but you can give 0.5 to 0.1 mgs of the 1 to 10,000, like a slow push.
That
You
used
can.
to actually be in a protocol. Yeah.
I think it was in it for critical care too.
Yeah.
I haven't looked. I don't remember though for right now.
So one issue that can be kind of a practical issue for medics is you've already got an IV established.
Mhm.
From the way I think, and I think a lot of other medics think, was ridiculous to give an IM medication when I've already got an IV.
Yeah.
But it's really more about that drug distribution profile and how long it stays in the therapeutic range. So for anaphylaxis, the IM epi really works better. Is that right?
Right. And there are less adverse effects from it, and it sticks around longer. So if you're giving an IV dose of epi, it's only going to last. But this is an option. You can do it. Okay, so back to the case. So he's the patient's allergic to shrimp. He's hypotensive. We've given him 2 doses of epi. He's gotten 2 liters of fluid, so we're going to start him on an epi drip. So I would say if you're having to give a second dose of epi, you need to start thinking, hey, we're probably going to need either push dose epi or an Epi Infusion. So start thinking about how you're going to make that. And then you can start at 0.1 mics per kg and then go up. So in this case, we started him on an Epi Infusion. He got better, and then you made it to the hospital, and he did well. All right, so other things that you can use in anaphylaxis are like H1 blockers like Benadryl, H2 blockers like Pepcid, bronchodilators like albuterol, and then glucocorticoids, steroids. It's important to know that none of these things are going to treat the underlying problem with anaphylaxis. You need epi to fix that. These are all just going to help your symptoms, okay? So H1 blockers or diphenhydramine or Benadryl really is just going to help your itching or your hives. And so that's really good when the patient only has urticaria or hives. They don't have any of the other symptoms. But if this patient has anaphylaxis and they're just, scratching themselves to death, it's very reasonable to give them Benadryl. And that's what we're going to do in the hospital. Famotidine or Pepcid is an H2 blocker. If given with Benadryl, it can help. A lot of times we'll give this in the hospital. Albuterol, you can nebulize it. It's a beta-2 agonist, very similar to Epi, so it'll help bronchodilate. And then steroids. There's not a lot of evidence that suggests that steroids help, but I will say that I always give them because what it can do is prevent that kind of biphasic reaction where the patient has anaphylaxis, they go home, and then they get anaphylaxis again. So steroids might help prevent that, which is why we give it.
Question, like in the new 10th edition, I noticed in looking through there, in the anaphylaxis protocol, it mentions salmeterol or methylprednisolone, which we know takes a little while to work. And
Takes
so
at least 6 hours.
But later on the protocols, and there somewhere it's got like Decadron or just plain old dexamethasone.
Yeah.
Preference, like, for those of us who, if you're going to order medications for your service or your organization, you've got a couple options listed there. Some are shorter acting, short duration. Is there a consensus from the positions on that.
What do you think, Dr. Ferguson? I feel like I used really only time I ever use Decadron or like dexamethasone or like croup or we're using it with COVID. But I feel like I give methylpred more often.
Yeah, I guess it depends on. Decadron's probably more versatile for more things.
Yeah.
Because you can give it for allergic reactions, you can give it for croup, you can give it for rash. The dexamethasone sodium phosphate, the injectable, can actually be given orally as well. So it's more versatile. But I'm like you, if I had a COPD or asthmatic, I'm probably doing methylpred. You can also carry hydrocortisone as well. So I think it's just something you sit down and talk to your medical director and determine what they want to do as far as that goes. You don't need all of them. You don't need
No.
one of each. That's ridiculous.
Say just one, it's probably fine. All right, so summary, if a patient's exposed to a potential allergen, something they're allergic to, think about anaphylaxis, give them IM Epi. If their symptoms get better, great, transport them. If their symptoms don't get better, consider push dose Epi or Epi Infusion. I will say in the hospital, anybody that has anaphylaxis, I would obviously transport even if you give them Epi because they can their symptoms can come back when that Epi wears off. So I think normally I would say I usually watch these people in the hospital for like 4 to 6 hours because we worry that biphasic reaction might happen. And then anybody with a severe allergic reaction, so if you gave them 2 doses of Epi, just think all these people are going to end up getting admitted. All right, a little bit about angioedema. So angioedema is more of a kind of self-limited, localized swelling. It's usually in the loose connective tissues. I'll show you right here. So like the lips, the mouth, the throat, the larynx, the uvula. You can get it in your bowel wall. So these people with angioedema, so say they have, swelling of the left side of their upper lip, but they also have crampy abdominal pain. It could be angioedema of the bowel wall. It can occur just by itself, or it can occur with anaphylaxis. So it usually has an asymmetric distribution. So if the patient has swelling of their both upper and lower lips, it may be angioedema, but I would say probably less likely. Usually I feel like I've seen it kind of more left upper lip, right upper lip, left lower, just one side. It can be associated with allergic reactions or anaphylaxis or not. So there's 2 different types. There's the mast cell mediated, which is the same mechanism, pathophysiology as urticaria or anaphylaxis. But that is going to be associated, if a patient has swelling of their lips, they're probably going to have the other symptoms of anaphylaxis. So nausea, vomiting, diarrhea, shortness of breath, wheezing, cough. It can also be bradykinin mediated. So think people who are on ACE inhibitors, lisinopril, or it can be hereditary or acquired. I know there are patients in Alabama who have hereditary angioedema who know that they have this and it happens to them a lot and they get treatment for it. This is not going to be associated really with any other symptoms. So you're not going to really see that. You might see some colicky abdominal pain from bowel wall angioedema, but they're probably not going to get nausea, vomiting, diarrhea. So big things for this are assessing their airway, their ABCs. What does their airway look like? Are they going to need an airway? Are they going to need to be intubated? Is their tongue getting huge? Does it look like their throat is getting full? Ask their history. Have they been exposed to anything new? So then you think, oh, maybe this is anaphylaxis. Did they just get started on lisinopril? Or have they been on lisinopril for 8 years? I've seen angioedema in patients who have been on lisinopril forever, and nobody really thinks about it. Have they ever had these symptoms before? Is this the first time, but their, grandmother and their father and everyone else has had angioedema, they just haven't had it yet? It might be hereditary. So when you're doing your physical, and asking your history, just ask, do you have any other symptoms of anaphylaxis? Because you can treat anaphylaxis with Epi, right? Angioedema, if it's just localized, Epi is probably not going to help. So treatment, obviously airway first. If they look like they're having anaphylaxis, give them IM Epi. For ACE inhibitor, really we just monitor these people. Sometimes we'll give them a anaphylaxis cocktail to see if that helps. It's probably not going to. If it's ACE inhibitor induced, really just stop their drug, list it as an allergy on their chart and tell them to never take it again. If they have a hereditary or an acquired C1 inhibitor deficiency, which has to do with bradykinin, there are certain medications that these patients can use, and they know it. Sometimes they have them with them. And then we can think about things like TXA and then FFP if they're in a hospital setting we can use.
The TXA will work on that pathophysiological process.
Do you know the answer to that? Because I actually don't know how TXA actually fixes it.
I thought Chief was at, okay, sorry, yeah.
I was like, I
So
did not look at it.
somehow in the clotting cascade,
Yeah.
the ACE inhibitors and ARBs cause an increase of bradykinin, or bradykinin, whatever you want to call it.
Mhm.
And TXA causes a breakdown of that in the blood. So that's the theory behind it.
Okay.
It works anecdotally in about half the people that get it, but it takes about 4 hours.
Mhm.
I've used it several times lately, and it didn't do squat.
Mhm.
But there's limited
There's nothing
risk.
else you can
That's not a
use.
medical term, but there's limited risk to TXA in angioedema for the most part.
Yeah, because there's not a lot of other options.
From a pre-hospital point of view, because pre-hospital setting, I've only seen angioedema associated with the non-anaphylaxis a handful of times. There's no way for us to know. If it's severe enough, somebody calls 911, there's producing stridor, which I've seen,
Oh, yeah.
right?
I mean, I think it's very reasonable to treat them like anaphylaxis.
So for us, we're going to treat them like anaphylaxis. My big question is where's the decision point for these patients to attempt an intubation?
I would say if they're having obvious airway compromise and they are getting swollen, the earlier you intubate, the better their outcome is going to be. Because if they are so swollen, we're not going to be able to fit a tube in when they get to the hospital. I would say intubating earlier is probably necessary. And in the state of Alabama, that means, I guess, calling a flight crew to come help you because the patient's probably going to be awake and alert, right?
So then you're looking at RSI. And
Yeah, yeah. And you really want somebody who's done a lot of intubations to intubate this patient. An iGel is not going to fit, most likely, in this. They're going to need a small tube, sometimes a pediatric ET tube, to get in. You want a very experienced person, and you're probably going to need RSI. Well, I say what we do in the hospital a lot of times is give them ketamine just to try and see if we can find a view and then paralyze them as we see the cords.
There's no one good answer except recognize that angioedema is bad
Yeah.
and that you probably can't fix it in the pre-hospital world. And sometimes we can't fix it in the ER.
Yeah.
So it's like a trauma or a STEMI. You recognize they're sick, so you start moving to the hospital as you do your treatment. And there's, like you said, I've used ketamine before, sedate them a little bit, put the blade in their mouth, with the video scope. DL on these people usually does not work out very well for anyone. And if you can get the blade in the mouth, the video scope, you can see the airway, then it's probably safe to give them a deeper sedation or paralytic and get them tube. But you don't want to paralyze somebody with RSI that's got an airway obstruction potentially, and they're breathing because there's no way to bag over that sometimes. So it's very concerning.
So what do you think when you see these anaphylactoid type angioedema cases, what percentage of those deteriorate to a life-threatening point? Because it seems like some of them are, they just sit there for a few hours and get better.
Right, but there's no way to tell which ones are going to sit there and not get worse. And after you see one or more people sit there and get worse, you realize that you're better off intubating early. So I have no problem RSIing somebody, sedating them, intubating them, and then 8 hours later, the inpatient doc calls and says, "Hey man, he's doing better." I'm like, well, "Great, extubate him," right? So it's just airway is the mainstay of treatment.
It's better to intubate them while you can than wait, excuse me, until you can't, and then they need a cryo or they need a trach and they have to go to the OR. Yes.
Deal with a bradykinin.
I will say anytime I've had like consulted ENT to come scope them, like angioedema, they're like, just give them all of the anaphylactic meds, and if that helps, great. If it doesn't, we'll go from there. All right, so summary, if a patient has some sort of allergen exposure, or they're exposed to something new, something they know they have an allergy to, and they have symptoms in 2 or more organ systems, or if they've had a severe reaction to this before, or if they're just hypotensive afterward, really think about anaphylaxis, give them IM Epi, You can give Benadryl for just skin itching, and then obviously constantly reevaluate your ABCs. That's my dog.
Very good. Thank you for that lecture, Dr. Brown. So just to share with everybody, not to be a war story, but something interesting happened within the last few months at Centerpoint Fire. And I think it's worth discussing because we've got this wall time issue going on. We had a crew with a fairly mild allergic reaction patient, had some hives, gave them Benadryl, the hives resolved, transported to the hospital, ended up with an extended wait time. While they're waiting on the wall, the patient develops full-blown anaphylaxis. We ended up treating on the wall. The medic did a good job of recognizing it, getting the physician involved really fast, and not being scared to go ahead and treat it because he knew what was going on. So that speaks to the possibility of the biphasic reaction, and it also is a testament to we gotta pay attention to our patients, be an advocate for our patients, even if we're inside a hospital and even if legally the patient's not our responsibility anymore. Which I know it's a big ask for everybody, but that's what we got to do, I think. I'm afraid those type of circumstances are going to continue to happen. So, and I'm just aware of the ones that happened at some point. So I'm sure there other ones have happened. I'm sure Dr. Ferguson, Dr. Brown can testify that they know of ones that are probably worse. But anyway, we got to keep an eye on the patients even when we're on the wall. Does anybody have any questions for Dr. Brown about allergic reaction or immunology?
So as far as the transfusion reactions you spoke of, would you expect to see the urticaria or hives localized to the IV site, or should you look other places for those?
I would say it probably is going to start right there, but it can be anywhere. But also with transfusion reactions, you can have all sorts of reactions. So you can have like an anaphylaxis or urticaria. Then you can also have like alt fever, like a febrile transfusion reaction, like a mismatched blood type transfusion reaction. There could be all sorts of things. But the thing that you can fix is stopping that transfusion, recognizing it, and giving them if they need it. Yeah.
Question, you gave a time frame as far as, like I said, as far as when a reaction would happen based on the route. Is that something we can use in diagnosing patients in the field and letting them know that if we're outside of that window, maybe you're past the point of having a reaction?
I would not. I would probably say no. That was just a case report of like 164 patients. So it's very small, but it just kind of gives you an idea of what you can expect. Because you kind of think like if a patient ate a peanut and now they're having all these symptoms, by the time you get to them, it might be 25 minutes later. So they could still get worse after that, or they could be bad already.
When you were talking about the angioedema and the bradykinin response, is that more of an anaphylactoid reaction, or what is the difference really between an anaphylactic reaction and an anaphylactoid reaction?
Number of exposures is one significant difference. And the anaphylactoid, correct me if I'm wrong, Dr. Brown, but what's causing the bradykinin response is contained in what they've ingested. It's not so much of an immune response. That's my understanding. And anaphylaxis, it's totally an immune response. So that means you can have anaphylaxis, but only at the second or subsequent exposure. But you can have anaphylactoid at any time. Could be first exposure, could be 10,000th exposure. Is that correct? Mm-hmm. And I understand it's mostly associated with ACE inhibitors, is my understanding.
Mm-hmm. I think there's been some data that shows like some NSAIDs can cause it, and a couple other medications, but ACE inhibitors I think are the most common medication that we see angioedema with.
There's another drug that you won't see in the fire service so much, but if you're in the EMS transport hospital to hospital, there's another drug that causes angioedema. It's basically if the patient is on an ACE inhibitor. Anybody know what that drug might be? It works on clotting things.
For strokes?
No, not TXA. TXA fixes, what'd you say?
For strokes?
For stroke, yeah, it's a drug we get TPA. So patients who get TPA, if you look at the literature, 2 to 8% will get angioedema. And then they say, well, actually, it's probably like 5 to 20% of people that are on an ACE inhibitor already. So anybody that gets TPA for a stroke, and then they start getting lip swelling or tongue swelling, if you're the guys or gals making the transfer, you need to address that with the physician at the hospital before you leave, because that needs to get an airway quickly. Because if you don't, the options would be a nasal intubation later, which will be a bloody mess, or a surgical airway, which turns into death, right? Because that's pretty bloody if they just got a thrombolytic TPA. So just food for thought. And that's a scary airway.
It's not uncommon. I've seen it several times.
Right. It doesn't, yeah, I've seen a lot of it. Most of it doesn't get bad, but you never know again which one gets bad.
Mm-hmm.
So I've heard of some physicians, I'll put it that way, in primary care, treating COVID patients by fairly long-term H1 and H2 blockers, along with inhaled steroids, kind of as an effort to reduce the inflammation that's associated with the disease. And those kind of long-term treatments, are you making the patient more susceptible to other infections? Does it reduce the immune
I would think
response?
so. And you're also gonna make them probably more reactive, because if you're giving them all those histamine blockers, they're gonna upregulate all their receptors for later. So now you stop taking it, might be a little bit more prone to having a reaction. I don't know the data behind that, but
Yeah, no data.
yeah.
Yeah, I would also say another category of patients, and I don't know the numbers, but just over anecdotally, is chemotherapy patients have a high instance of both anaphylaxis and anaphylactoid reactions because of the exposure to various chemotherapy agents. So sometimes you might be called to a oncology practice. I know more and more oncology practices are off-site from the hospital or kind of standalone. And so you may be called to help manage an anaphylactic reaction at one of those clinics.
Yeah, I mean, I know Birmingham gets called to Kirkland Clinic a lot for that, and they all bring them to the ER.
Very good, great discussion. Any other questions for Dr. Brown?
What about the pediatrics? I know, and that's a Shaduri question, but, you know, you've got an EpiPen program in schools now where schools, faculty, and staff can get kids with an EpiPen by protocol. They have their own thing, but we know kids respond really, really well to Epi. So any evidence one way or another beyond how we would normally treat or currently treat? You know, we're seeing more kids with allergic reaction. They're getting popped with EpiPen in junior. Sustained, but particularly like out in some of our rural areas where we've got the 20-minute response time for an ALS unit to get there. Mm-hmm. And then you may have 20-30-minute response time just to get to definitive care. Any recommendations, suggestions besides keep pumping Epi? You know, steroids.
I mean, you can give steroids, but it's not going to work for 6 hours.
Yeah.
At least. But you can do it.
I know Dr. During always says that kids react well to Epi and react well to fluid bolus.
Right.
You think about risk to benefit for any drug, right? And there's probably limited risk to giving a kid IM Epi. What's going to happen to them? Worst case, they get a little bit tachycardic or something.
Yeah,
the 60-year-old with underlying heart disease, there's a potential more of a risk than there is for kids. But you're right, the pediatricians give a lot of Epi. So
that's a good question though, because I've always wondered about infants, especially neonates. Mm-hmm. I know that they don't really have a developed immune system. Until they're 3, you take something like that. I mean, it's a couple of years. So I don't have a lot of experience there, but signs and symptoms and assessment of anaphylaxis in that age group seems to be pretty difficult, right? Mm-hmm. So it could be no skin signs, could just be GI upset. Is that right?
Could be, but they're not going to be able to tell you probably that their stomach hurts.
Yeah.
Well, they might be vomiting or have diarrhea, but
they can't communicate.
Who knows
they
if
get lots
that's
of rashes anyway, but
right.
diffuse, fine rash versus like
But hopefully the mom at that age, mom or dad will be able to tell you what they've ingested or been around, or they're probably not going to be. I mean, if they're 3, they're going to be running all over the place. But hopefully you would have an exposure that would be known.
All right, very good. Thanks for everybody participating. Thanks for everybody that showed up here, and everybody online. Remember, online, you can get your certificate by either clicking the link that's in the Q&A you find on your computer. If that's not available to you because you're on a phone, you can send an email to Alabama EMS challenge@gmail.com. That'll produce an automated response with a link to the form. And Dr. Ferguson, you got something?
Just, I wanted to touch base on the Epi dose. Remember, Epi is, like Chief Ward said, is tough to get some of these medications now. So if you're gonna make push dose Epi out of your 1 to 10,000, I know some folks like to squirt 9 cc's out of it, and that just wasted a bunch of your Epi. So just be aware, some drugs are gonna be on back order soon. So use them wisely, don't waste the drugs. The other thing, I know we talked about doing 1 to 10,000 Epi for anaphylaxis IV. I would say, please do not use that in the Brims region, or if you work with me. If you do, shoot me a text or email, let me know why you did that. Obviously, don't let someone die in front of you, but there's a big risk to Epi 1 to 10,000 pushing that IV. So be very wise with that. The other thing, somebody talked about the blood reaction. You won't see a lot of those these days because there's no blood to give anybody. Not funny. So if you want to donate blood, please do so. It's pretty sad. You look in the trauma bay, we look on the wall and how many units of blood we had to give that day. And some days it's pretty concerning. So if you can donate, please donate. And then the last thing, talking about everything going category A. Again, I said earlier, that means that your responsibility just shot up a lot. So make sure you know what you're doing. You understand the drugs you're giving. That doesn't mean that you can't call for help if you have a question, okay? But if you don't call, you better be right? So that's all I got. Thanks for smiling.
Thanks, everybody. Appreciate everybody's participation, and we'll see you next time.